Awesome. Thank you very much, Liana. Hi, everybody. We really appreciate you guys taking the time during this lunch break to, oh, well, lunch break for some of you, actual work for some other of you. But anyway, thank you very much for taking this time to join us on this webinar that SLIP, Serving Latinx Populations, is hosting. And as a reminder, SLIP is a part of the PCBH SIG. So thank you all very much. I'm just going to give you a very brief overview of what we'll be talking about today. As you all know, this whole situation of providing telehealth services during COVID has been one that's gotten a lot of attention due to the many challenges that we've had to face, and how do we go on about continuing to provide integrated services. This webinar will be focused on how we're able to continue providing these much needed services to our Spanish-speaking Latinx communities that we all serve. Telehealth doesn't come without its own challenges, so our panelists, all who are behavioral health providers, will go ahead and discuss the various barriers and the creative solutions they've implemented to effectively meet the needs of our Spanish-speaking Latinx patients. I'm really excited that we also have Puerto Rican representation today. We'll be one of our panelists actually provides services in Puerto Rico, and she'll be talking about her experiences on the island. I do want to give a quick intro of all our panelists. Dr. Yaira Oquendo Figueroa, she got her PhD in clinical psychology at Ponce Health Sciences University in Ponce, Puerto Rico. More Puerto Rican representation here. She's currently the Director of Training for Behavioral Health at Salud Family Health Centers in Colorado. And her primary interest is providing supervision for native Spanish speakers and bilingual psychology postdoctoral fellows, psych interns, doctoral psych students, and international students. Dr. Valerie Toro Rodriguez is a clinical psychologist also in Puerto Rico, or from Puerto Rico, and she is the one practicing in Puerto Rico. She has 2 professional certificates, one in couples and family therapy and the other one in primary care behavioral health. And she's an associate professor at the School of Behavioral and Brain Sciences of Ponce Health Sciences University in Ponce, Puerto Rico. She's a clinical coordinator of primary care psychology program of the Ponce Research Institute. And we're very fortunate to have her expertise here today as well. And I'm going to hand it over to Norma so that you can hear her voice as well. I'm sorry, I forgot to mention, I'm Yahaira Johnson Esparza. I'm one of the co-facilitators of SLIP along with Norma Vali-Borrero, and I'll let her take over and introduce our next panelist and give you some additional information for the webinar.
Hello, so my name is Norma Vali-Borrero, and yes, thank you to those who told me that you could hear me. So I am in clinic today and had a last minute patient. I'm sure you all know what that feels like. So yes, our following panelist is Miss Shandy Gonzalez, who is part of our BHC network here in San Antonio. Shandy is super cool because she got to train with, I'm gonna pull up your bio here, Shandy. Is this not in your bio? Oh, you didn't put in here, but she actually got to train with Bauman and Beachy, and she's part of the Methodist healthcare system here now. And she also is a certified rehabilitation counselor as well as a licensed professional counselor. And also, Shandy and Yahaira, you are starting something here for South Texas too, isn't that right? I remember getting an email about that.
Yeah, we are starting a kind of a networking group that was in existence a few years ago, but hasn't really been active. And so we're hoping that our first meeting will be in the fall, and getting that going and meeting quarterly, based on, different topics that people are interested in, bringing in speakers and just meeting other BHCs in the area.
Very cool. Yeah. And so something that Yahaira and I really appreciate about our panelists is they're all working and located in different areas that present different challenges. So, Shandy's here in an urban region. And then Yaida is in Colorado with more rural populations. And then Valerie is with on La Isla, you know, with working with all the challenges that Puerto Rico has been going through. And my family's from Puerto Rico too, so I'm excited to have y'all here. Another thing that I wanted to mention before I pop off for a second for a patient is that if you have any questions, please enter them in the chat box. Yahaida and I are going to keep track of them and then ask them at the end. So please feel free, if something comes up that you really want to know, you know, enter it there. And I also wanted to just check in with everyone and see how they're doing. And I put a poll in here, and it looks like that poll is not there. Let me activate that. So I'm going to send, I did activate it. Let me send it through the chat. So go ahead and take a moment. Let us know how you're feeling. You can go to that website. So I know it's a stressful time for everyone. The world is constantly changing. So just to kind of test the temperature of the room, and I'll hand things back to Yahaida. So I just heard from Yahaida that she can't hear.
Oh no.
Is there anyone else who cannot hear someone? Can type it in the chat. All right, so we're getting responses. All right, let's go ahead and start. Yahaida said, let's start. And it looks like most people are the light green happy. So that is nice to hear too. All right, let's go ahead and get started. Take it away, Yaida.
All right, so I'm very happy to be here. Of course, these women are fantastic, and I'm very happy to have to be part of this collaboration. So I'm gonna start talking about my role as Director of Training for Behavioral Health, but also supporting the behavioral health providers that we have at Salud. I wanted to bring some information about the fantastic work that they have been doing since the pandemic started. Salud holds a lot of pride because we have been able to increase the bilingual behavioral health providers that we have in our clinics. Right now, 80% of our behavioral health providers can provide services in Spanish, which is fantastic because Salud mission is to provide access to the underserved, including dissipating any barriers that has to do with language. Something that we have been noticing is that the behavioral health population is changing in the sense that we're having more behavioral health providers who prefer Spanish as their language to talk every day. Right now, we have 33% of Spanish as preferred language. Some people coming from other countries, some Puerto Ricans as well in our clinics. And this is very interesting because it talks about their own background and where they're coming from, and speaks about the provision of direct client care, being bicultural, bilingual. 80% did not have previous experience with telehealth. And I wanted to bring up to your attention because as managers, supervisors, administrators, we had to consider what we had in place and what needed to be done in order to provide the services for our Spanish-speaking patients or patients overall. 70% did not receive training on telehealth prior to the pandemic. And at the same time, this has been a challenge for them to be able to get the competence needed to provide the services. I have to say that we have around, there's a question here, how many behavioral health providers are in Salud? We have around 30 to 35. We are in a transition right now to having more behavioral health providers, but that is pretty much what we have across our system. We have 14 clinics across the northeast of the state and south. Before the pandemic started, some of our behavioral health providers were trained in the provision of tele-behavioral health services between clinics. to be able to provide the care to those very rural populations that there was no enough behavioral health providers to take care of the population over there. So there was some technological resources already available, and they were protocols, and we discussed about ethical issues or possible considerations to provide services when you are in a clinic, let's say in one city, and you're providing services to a different town. So that was good because part of our behavioral health providers were trained on that, especially the behavioral health providers within the training program. So one of the things that I did is that I asked them, okay, so what do you think that are the challenges? I have been able to provide services during this time, but I wanted to see their perspective, especially because they are located in different places in the state, in different clinics. So the first one was lack of visual cues to understand patient emotions. And if you think about it, when you ask in Spanish, ¿Cómo estás?, the natural response is, oh, bien, estoy muy bien. And we rely a lot on visual cues to understand the underlying emotions of our patients. The majority of and I have to clarify, yes, we're providing some video conference services, video call services, but the majority of the services are by phone. This is because it's more convenient, especially, to deal with the patients that are already there, that they don't know that they were having a behavioral health provider calling them. So it's easier, especially also to deal with issues related to the patient not having the technology needed to access their providers. Not having printed materials at the moment, so we have to figure out how to send stuff by email or by mail. And this requires more planification. Again, if we are doing consultations or screenings, we have to spend maybe more time to make sure that the patient gets the material that the patient needed. Difficulties explaining body reactions by phone, as you can imagine. We use a lot of nonverbal, with hands and all of that to explain emotions. Family members in the room, what is the meaning behind receiving behavioral health services, and what is the opinion of other family members? There is some sort of stigma sometimes, and also we can talk more about boundaries in the family and how this affects. Long work days. This is a problem that we had before, but right now the issue that we have is that when we're calling the patient is at work. So how do we manage that situation of calling the patient while the patient is working? Inability to assess the mental status examination completely. This brings difficulties with patients who are using substances or patients with memory difficulties and all of those things. And naturally, technical difficulties that I imagine that you have been through all of those things. When other desafios or other challenges has been psychological testing, the reality is that Salud Serve, I don't want to say that we are the only ones, but there are not a lot of places that are providing psychological testing for Spanish-speaking patients. And not being able to access this because of the pandemic has delayed some processes for immigration purposes or services at school, which are extremely important for our patient population. Behavioral health providers in training, they were learning something, and on top of that, they have to learn more things and pretty quick. That has been a challenge for supervisors. We had to redesign integration, how integration looks like when everything is done virtually. And patients in other states and countries, what we find out is that patients were stuck here. They were not able to travel, and they had to find services immediately because they did not have the capacity to go back to their countries, or they were stuck in other states without the capacity to come back for any reasons. So how do you manage that? What are the implications of having patients in different states with other family members? And the other thing that has been always in the back of our mind is a state telehealth regulation. What is going to happen? Are we going to be able to continue providing services and get reimbursement by the services by phone? And understanding my next point, that we need to have multiple approaches for the provision of services for the Latinx. I think that the best awareness or reflection or lo obvio que hemos visto is that we need to have different options to be able to, if we want to improve access to care, we have to have telehealth by video or telephone or in person, and all of these opportunities to increase that access of care. We need to, something that was very important is that some of the behavioral health providers said, hey, it seems that we are seeing other issues in terms of diversity. We would like to have a diversity series on the provision of telebehavioral health. Because if you think about it, you are entering to the patient house or work, and you're seeing interactions that you were not seeing before. One great opportunity that I have been trying to create is community involvement, different community groups that can work on providing technology literacy or technology education to or Spanish-speaking patients who are older adults or for any reasons were not able to access technology education before. For example, somebody who came to the country pretty recently, and this is the first time interacting with this concept of having video conference with their medical provider. So I think that we need to do a lot of work connecting with the community to be able to increase that education, that information to our Spanish-speaking patients to be able to access behavioral health services. I'm gonna move on and let Dr. Toro Rodriguez.
Thank you, Jaira. I'm very happy to be here too. So I'm going to talk about the perspective in Puerto Rico. Like Jaira said, I'm part of the Primary Care Psychology Program, or PCPP. Our program is part of the Clinical Psychology Doctoral Program at the Ponce Health Sciences University. And we have, like, to put you in perspective, several grants for providing ongoing training to practicum students, predoctoral interns, and clinical psychologists to provide behavioral health services in primary care clinics and specialized care clinics around the island. Some of my duties in this program is to coordinate some of the services, provide training and supervision for the interns and students. So in Puerto Rico, before COVID-19, you can pass the slide, sorry. Before the COVID-19, telehealth services were almost non-existent. So before the emergency, Puerto Rico had 2 laws for the regulation and the use of telemedicine, and none of the laws included behavioral health services. In March, we got the permission from the Psychology Licensing Board and the insurance companies to provide telehealth services only during the emergency. So with this context, our reality was that none of us, administrators, supervisors, students, or interns, or clinicians, had previous training or experience in this area. So we had a lot of fear about providing services, mostly in the context of crisis intervention. And we had, like, diverse openness in the clinicians and in the administrators to provide the services. Also, another challenge, because we had to continue our services, we had little time to get trained and start providing the services in something that we didn't know about. And we had to train ourselves in what I call a fast forward mode. Also, with the physical distancing restrictions that we had in Puerto Rico, we had, like, the lockdown very, very quickly. Another challenge was maintaining the integrated care model. Some clinicians were providing the services at home, others were providing services at the clinics, and as good Puerto Ricans, we prefer the close contact with others, so that includes our teams, our work teams. Clinicians were used to discuss the patient needs and the important information for their care in person with the staff. So changing the way that therapists interacted with their healthcare team was a big challenge too. Also, another challenge is that before COVID, all the encounters at the clinics were face-to-face, so the clinics were not completely prepared to provide the telehealth services. For example, not all the clinics had phones in all the offices, or the ones that had computers, the computers didn't have cameras. So that was a challenge too. We also experienced challenges with our patients, right? Like most of people, most of clinicians. Most of the patients that we serve are economically disadvantaged and have no familiarity or accessibility to technologies. We thought like video conference was like the best way to intervene with the patients because it's a little bit more alike with the face-to-face intervention, but we found out that most of our patients didn't have internet, didn't have phones with cameras, didn't have computers with cameras. So the more accessible form of continuing our services was by phone. Also, in Puerto Rico, we have a growing population of older adults. So a big part of the patients that we serve are in this age category, and we found a resistance in receiving telebehavioral health services from the patients of this group. As the phone visits, some of the clinicians experienced difficulties in maintaining boundaries and structures of the interventions. For example, maintaining the time, brief interventions, and maintaining their conversation about their health or behavioral health difficulties. Here, our hypothesis is that the value of personalismo played a role here. We know that Latinx prefer informal interactions also, so we think that maybe the patients interpreted the phone calls like it was like a phone call from a friend or a family member. So we had to deal with that. And another challenge, it's been confidentiality. I'm sure that everyone has been having that challenge. A significant number of people live with immediate and extended family. So privacy of the intervention with other people around, and with the lockdown, everyone had to be at home. It was definitely a great challenge. So now I'm going to talk to you about our strategies. I also divided the strategies in the providers strategies, or the strategies for providers, and the strategies for patients. Some of the things that we did the first few weeks that we had the lockdown was preparing the protocols, the consent forms, and training for our students and our staff. Because we are on a program that provides ongoing training, we used that designated time of that few weeks that we had already for training for the students to revise literature. That literature was discussed. They all had the APA telehealth training series. And after training, we also scheduled virtual meetings to practice with the students and the interns before they began seeing the patients in this way. In some of the clinics, the administrative team was the ones that made the protocols for the telehealth behavioral health interventions. In other clinics, the practicum students were the responsibles for the development of the protocols. And after they developed them, they discussed the protocols with the supervisors, with their peers, and also with the administrators. This was like a teamwork. Listening the patients, what the patients had to say, listening the clinicians, listening what the administrators had to say, and create like a balance with all these people like providing feedback. Also, some of the behavioral health providers had to change their workspace. Some began providing services from home and others from the clinics. So identification of phones, computers, and office spaces to provide the services was also made. And for the integration of the services to manage that, the clinicians started using the phone also to integrate with the rest of the team. Phone calls were implemented to discuss the cases and provide the appointments in a coordinated way. The strategies for the patients. After the training and the protocols were developed and before formally implementing the telebehavioral health services, some clinics implemented an orientation call. In this call, the behavioral health provider explained the patient about the telebehavioral health services, what is it and how we were going to do it. And also in this call, it was explored the openness of the patients to receive the services, their preferred and most accessible technology, their preferred time of the day for the intervention, and the identification of a private place at home. Some of the providers also changed their agendas to provide the services and match the clinic and the patient's agenda. Some clinicians also use the administrative time to develop psychoeducational brochures and written instructions with specific skills, for example, relaxation techniques, and share them with the patients who had email. I think this helped with the structure and the time of the intervention. So I think this is all my part, and I'm going to let you listen to Shandy.
Let's see here. Can y'all hear me? My unmute button is.
Yes, we can hear you, Shandy.
I was gonna say the Zoom, there's an icon on my mute button and I can't see what status is. So I am here in San Antonio, and so just like they had mentioned, I'm primarily in an urban area. The BHCs work out of 2 primary care clinics, and so the clinics address the medical and dental needs of individuals who cannot afford health insurance. And Yada, you can go to the next slide if you want to. We have 4 behavioral health consultants. We're all bilingual. One of us is actually trilingual. So we have 2 LPCs and 2 LCDCs. Our 2 clinics have 8 medical providers and 3 psychiatric providers, as well as other team members from other departments, but those are kind of the main ones that the BHCs work with. Only one BHC, let me check out the questions really quick. Okay, only one BHC had prior experience working with telehealth to this degree. And 2 other BHCs had received prior training through other jobs. Our clinics, we use the same system, and so for coverage, we were familiar with telehealth from one clinic to another, which was easier and facilitated by, you know, the nursing staff, or even ourselves. We could set it up and get it going, and so it was very different connecting to individuals in their own homes. And let's see here. So our clinic, I didn't get the stats on how many people are Spanish speaking. If y'all are interested in that, I can definitely get that for you. But we have served patients from different countries, like the ones that you see listed. In Mexico, specifically, some of the states that I've seen are Tamaulipas or Coahuila. And the cities, we're talking about like Monterrey or Piedras Negras. And so I was somewhat surprised that I have seen a lot less people from Tamaulipas, considering how close we are to the border. We've actually seen people from, you know, more southern countries. So we can go on to the next slide. So our current process right now, basically, you know, whenever there is a referral that comes through for a behavioral health consultant, we all see it come through in live time, and we have figured out a way to communicate with each other. Even when we were in clinic, we rely heavily on HIPAA compliant chat platforms. And so to kind of let us know, hey, you know, you're needed in this room, or if somebody has a question, or, you know, especially with us being different clinics, the BHCs at one of our, well, actually, I guess, yeah, two of the BHCs at the clinics will be working with both medical and dental. And so we're actually having to move between different parts of the clinic. And so we're moving around all the time. And the way to really get a hold of us sometimes is through our chat. And so we've been able to continue that since working remotely. And so that's because that was already in place, that has worked out really well. To kind of echo some of the things that have already been mentioned, primarily when we first started, we did a lot of telephone visits. We used an application called Ring Central, and that was kind of what we used primarily. Psychiatry used Zoom. We started to transition a little bit over to a different application called Doximity, just to kind of figure out what works best, what's more user-friendly, considering the different barriers that patients have. For the BHCs that started to roll out mid-May, and what I've noticed is that a lot of patients, when given a choice, they choose telephone. And so I don't know if it's, it would be interesting to see if part of that is just not being familiar with the technology aspect of it, the types of technology that's being used, maybe experiences with other providers, whether it's us or school or what have you, that they just haven't really been able to get it to work, and so they're just kind of turned off by it. But a lot of times they prefer phone visits, and so we're mindful of that, but also we're really trying to push for video calls and telehealth via video, considering that we're not quite sure moving forward what the status will be of telephone calls, reimbursement, if that'll be acceptable. Even when we're in clinic, we are able to do follow-up phone calls, but that's not, at least for myself, not something that I did regularly. And so now I can definitely say that I'm much more comfortable doing that. Something else that we started to come up with, or we didn't want to be necessarily sharing documents with patients from our direct email, and so we created a behavioral health generic email where we could have documents sent over to patients from that email. And so maybe somebody wanted some psychoeducation on coping with depression or sleep hygiene or what have you. We were able to send it through that email and not have to be concerned about, them reaching out to us in crisis or what have you, and taking the steps necessary to protect HIPAA. And we've also created we identified some infographics that were already in place related to COVID-19, especially with our population. What we noticed was a lot of just misinformation about what it was, how it could spread, what to do, what not to do. And so we identified some infographics on just general information for COVID-19 in Spanish and English, some different coping strategies and techniques to try at home, and COVID-19 as it related to potentially an increase in alcohol use and smoking. And the last thing is, we tried to continue to figure out, or not figure out, I guess figure out is the correct way, how to coordinate care as seamlessly as possible with other departments that we have, that we're very fortunate to have working with us. And so that included psychiatry and counseling. And so that's kind of our run through of how on the BHC side, what our process is like for patient care. And so some of the challenges that we have encountered or talked about as a team are, one I already talked about, so the phone visits. Once those are no longer as acceptable or maybe acceptable at all, that might be something that really becomes a big challenge. A lot of patients just do not have access to internet or phones or computers that have access to video, and so if we no longer have that as an option, we have to be creative about figuring out other ways to connect with individuals that need services but don't have access to those needs. And so to echo something else that was brought up earlier, it's just phone calls initially, they ran late. A lot of times we were maybe some of the only people that are reaching out to the patients. And so it was just, let me tell you everything. And at least when we're in person, and this probably goes all around, whether it's Spanish or speaking patients, people can pick up on cues. They can pick up on, the nodding, you know, closing your computer, getting up, walking to the door, just different things to kind of, you know, prompt people that we're wrapping up. And so when we're on the phone, that's not necessarily something that is as easy. I found it a lot harder to redirect some individuals. And so it made my consults initially run long. I think that now I have a better handle on that, and I don't know if maybe it's just over time people feel less stressed, at least here in San Antonio, as things started to open up and people were starting to be able to go back to work. But that was something that initially we found a lot of. Let's see, some of the barriers were also just patients not picking up. And so I might get an order from a doctor that just spoke to that patient, but then I call them and they don't answer. They don't return our calls, or maybe we're reaching out to patients to just kind of check in on them that we've been seeing, and the lines are disconnected. And so those are some of the barriers that we've run into. Other things are confusion about roles and services from both other team members and patients. Sometimes I'll call them, and because they've been receiving different calls, they're not sure if I'm the case manager or if I'm the health educator, or, you know, if I'm the nurse. And so that had been a little confusing. And for some reason, once we kind of left clinic, the process got a little bit wonky of how to reach the BHCs. And so sometimes we would get referrals for things that weren't necessarily things that we addressed. And so that was some of the confusion as well. And we've had to increase coordination of care remotely. And so when we're in clinic, as you're able to just do things, print out things, get people scheduled, do this and that. Now we're all far away. And so if we had to get an appointment scheduled, or if we needed if they had a medical question and we needed to connect them to medical or to their doctor, then that was something that required additional time and additional effort and just more coordinating than occurred in person, because it was just easier and faster and more organic. And then the concerns about confidentiality, and something that I didn't quite get into, but I'm sure that, you know, we've probably heard about this, is the increase of domestic violence and child abuse. And so whenever we call patients, and it may be related to stress associated with their situation at home, you know, when can they talk to us, and will they be safe doing so? And so those are all things that, you know, we had to be really mindful of and navigate. Then for the next slide, so some strategies that we came up with as a team. We are really, really fortunate to have different disciplines with us. And so some of the things that we came up with, or continue to work, other departments we continue to work with, is case management, you know, making sure that patients, as they're able to access specialty medical care with healthcare referrals. One of the things that was really helpful, especially initially when we closed down, and, you know, patients still needing food, if they were eligible with us, then we could coordinate them picking up a food bag. And so that was something that, you know, a lot of patients used. Other things is, I believe medications are still being mailed. And so that was a way to kind of, for people that had transportation issues that couldn't get to the clinic, or a pharmacy being closed. And so that was being mailed out. Nurses for different medical and psychiatry doing walkthroughs with patients before the appointment. And so making sure that their audio was working, that their video was working. That way, once they had their appointment with their provider, there was decreased technical difficulties. And so, and also made them feel more comfortable about what it was going to be like and all of that. And we've also been able to, the recreation and enrichment department has been able to, for patients that had access to Zoom, they've been able to do different activities via Zoom, like yoga and exercise and Zumba. And so even though patients may not be able to get out and exercise, this might be something that they could do as a family or do at home that is free. But again, it goes back to, you've got to have access. And so, some other things that we've tried to consider is trying to find a platform that is just easy. Sometimes, you know, if the literacy is not there, or, you know, there's just other, like vision, challenges with vision, then if we're sending you a link to Zoom with a code and an ID and this and that, that gets really confusing. People, might have some trouble with that. And so figuring out a way to be more easily connected. Those are some platforms that we're trying to figure out and identify. And then creating flowcharts to help the different team members kind of walk them through who needs to be contacted for what and when. That way we're on the same page and it's easy, because with us working from home, now we're having to manage a lot of additional things. And so this wouldn't be something that makes it easier. And so if there's not already a protocol or flow chart in place, that can be something that can make potentially decrease frustrations and just improve quality care for patients. And the last thing is kind of getting back into those huddles. And so when we were in clinic, we were having huddles, and now we haven't been. And so that's something that we're hoping helps to ensure that people don't fall through the cracks, that people are getting the care that they need. And so that's kind of the way that we're addressing some of the things that have come up in the last, I would say it's been about 13 or 14 weeks for us now, give or take, something like that. So that's it.
Wonderful. Thank you all so much. So Yaida, if I could have the screen for a second, I just wanted to share this final poll that has the all the words that everyone entered of what they learned. So could you transfer it to me? Or can I just share my screen? Let me see. Nope, okay. All right, Yaida, if you stop sharing your screen, all right, beautiful. And all right, prepare yourself. My desktop is very frightening. I have a lot of documents. Okay, let me see if I can do this. All right, so that's not too bad. Where's my poll everywhere? Nope. Oh my goodness, where's my poll? Huh, give me a second.
If you don't mind, I would like to answer one of the questions that I saw in the chat in the meantime of you figuring the whole question out.
Yes, go for it, go for it.
Great. So one of you asked me about the psychological testing that are done at Salud in relationship to immigration. Fill out for to take it so that you're able to hear me. So hopefully you're hearing me well. Great. All right. So and that's pretty much the nature of great. We cannot hear you very well. Yeah. Hopefully that is fixed. I can, yes, great. So yes, the testing, it's, we do different type of testing, but the one that I was saying, it's about the action for the exam.
Okay, try it again. Because you did start breaking up when you started talking about the testing again.
Yeah, I'm not sure what is going on. All of a sudden, it's sending a lot of about my connection. It was pretty weird.
No, right when you get to the good stuff, then it starts breaking.
When I'm getting to the good stuff is then when my connection is not good. Yeah. So again, the other question was about training. Training in psychology is another topic, big topic, and that's something that I love talking with some of you who are interested. People who are living for any of you are interested.
So I'm wondering, Yaida, if you could type out all your awesome response just in case. So sorry about this. Oh, technology. And I'll share our little infographic now because I found it. All right, here we go. All right, so full screen. Okay, so we have different school therapists, patients, cannot. I'd love to know more about the cannot. That sounds interesting. Places useful. Okay, very cool. Different. I think we can all agree that this experience has been very different for everyone to adapt to. All right. Okay, well, I know there are some other questions that came through. So let me go to our list and get that started. Okay, so one was about the training and protocols. So if you want to speak to that, Valerie, about the protocols that you made.
Yes, because the clinicians were very worried about what we're going to do if we have a crisis, or how are we going to approach the patient. We are not seeing the patient, so we developed a protocol like step by step. For example, the first thing you need before calling the patient is the medical expediente. So you have all the information of the patient there. Talk to your healthcare team. Tell them, the case manager, the physicians, that you're going to call a patient so they can help you if you have a crisis. Other things, like we develop like a shorter screening, so they can do like a pre-screening by phone and ask the patient some specific questions about their mood, about maybe anxiety, and their health status, and then stay like focus on that questions and those answers, and manage like rapidly the the queja that the patient has right now, and try to manage that as quickly as possible. Have the help of the team. Talk about it with the team in your clinic. So maybe as a team, you also can add to that protocol some other steps.
Thank you. That's awesome. And oh yes, so some of the questions that came through the actual Zoom. Yes, thanks, Shandy and Martha. Okay, so one is how have you gotten patients off the phone? So I think everyone mentioned how it can run a little long, and that closeness, and it's hard to, I found, because I work predominantly with kiddos, that sometimes it feels like you're their only lifeline with everything that's going on, and it feels like, I don't want to be rude by like cutting you off, but I do have other patients. So what have y'all found as a way to kindly, politely, professionally cut that call? Yeah, anyone can answer. Just jump on in.
I will try. Let's see if my microphone works. Well, the first thing that I think it has worked is to establish
Oh man, apology.
Okay, so I'm gonna help Jaira. One of the things that we did in that orientation call that I mentioned earlier is orient the patient that the intervention is going to be mostly the same intervention that we do face-to-face. So the time frame is the same. The issues that we like manage in the interventions are going to be the same. So that orientation call, I think we made, or the clinicians made the orientation call before starting the telehealth services. So the patient was oriented before. I think that helped a lot. And Shandy talked about the cues that we can use like face-to-face with the patient. I think it's very important that relationship that you have with the patient, to talk to them, be, you know, transparent and sincere. I validate the feelings, recognize what they're telling you, and then tell them like, I think that is very important what you're telling me, but maybe we can talk about that next time or something like that to, you know, wrap up. Something that personally helps me a lot also is the resumen, to, you know, like talk about review of what we already talked about, and that gives the patient the cue that we are finishing the intervention.
Awesome. Thank you, Valerie.
Just to add to that really quickly, part of the orientation, this is more, I guess, towards the beginning, definitely not at the end. I let them know how long it's going to take, and I let them know that it's going to mimic the pace of the visit with their provider. And so that way, as I give them additional information in the intro, I think the intro is incredibly important, especially as BHCs, and even more so maybe right now they're doing services over the phone or video, because they may just have, they may remember, especially if they've seen us before, what our role is or how our visits usually run. But you know, things change, and so I let them know how long it'll be. And if I notice that, you know, I'm maybe at about 10-12 minutes and I still have a whole lot more that I needed to get to that I haven't got to, I let them know, oh, okay, you know, you know, I validate them, and then I let them know we're going to go ahead and keep going. I have a few more questions, and that we'll go ahead and get to the intervention. And so that way they're aware, like, that there's a process to it, but keeping them mindful of the time. And so I let them know, not minute by minute, but I let them know kind of where we're at, like, oh, you know, we're almost to the end. And so these last couple of minutes, let me just go ahead and ask you these final questions. And so that way, those are my verbal cues of letting them know, hey, like, we really need to wrap up. And so that seems to have been helpful. And if it's a follow-up, then if I already know that there's one that's harder to redirect, then I'm prepared when I go into that visit, or better prepared than when I find out at the first visit that this is going to be one of those consults.
Great. Thank you, Shandy. So yeah, we're almost at the end of our time here. Then I think, yeah, Haida's connection is more stable, so she's going to join us again.
Thank you. Thank you all for just the richness of the info provided us, and just how the different perspectives that you bring to us, seeing how you guys all have slightly different roles. Unfortunately, there's not a ton of time, not as much time as we would like, and we had way more technical or technological issues than anybody should have in the Zoom call. But I'd like us to keep this conversation going online. So if all those lingering questions you all have, please send them to us, and we'll go ahead and send out information on the listserv and how you can join the SLIP listserv, so that we can go ahead and field those questions and share them with the panelists, and maybe they can then give us some answers, some written answers for that, and then we can distribute those through the listserv, because I think there were some great questions on training, additional information on like assessments to help our patients with their N648 medical exemption requests. By the way, the MOCA can be administered remotely, so it's one way that we've been able to continue helping our patients, right? So all these questions, please go ahead and send them to us, and we will do our best to get you these answers via email. What I did want to ask, Norma and I wanted to ask all the panelists is in like 1 or 2 words, and we mean it, guys, 1 or 2 words, Tell us about the uniqueness of working, let's say 3 then, uniqueness of working with patients who are Spanish speaking in this like new uncharted territory, right? Lo desconocido que hay ahorita around telehealth. So in up to 3 words, tell us something about the uniqueness. I know it's a tough one because you want to say more, I bet.
Gratefulness. They are grateful for our calls. They are looking for that warmness.
And we heard that. Hooray,
I think they're very grateful, and especially, these are not 3 words, but especially in the time that we got the lockdown, that they didn't have like relationship without people outside their homes. They were like, oh my God, my clinician is calling me. I'm so grateful for that. So that's my experience.
My experience has been similar. I would say they've specifically said the words grateful. I've also heard them be hopeful. And they'll say, I'm so glad that you're, not in the clinic. I'm happy that my doctor's calling me, that my nurses are calling me, because it lets me know that you all are safe. And so it's really, nice to see that they care about us as much as we care about them.
Yeah, that's beautiful. I'll echo that too, Shandy, because a lot of times when I call my kids and parents, they all ask me how I'm doing too. And they want to make sure that I'm okay. And that's really touching and makes the world feel a lot smaller in a good way. All right. Well, thank you all. And Yahaira, bring us home.
Thank you. We do want to be mindful of your time. Shane, plug here, please, whoever's on this call, join SLIP, Serving Latinx Populations, the listserv. I think there's a slide, but somehow we lost the slides. But we'll go ahead and send out an email reminding you all to please join SLIP. The more people we have, the better opportunities to be able to bring some really awesome webinars to y'all. So totally shameless here. Thank you all. Thank you, panelists. We appreciate it. Thank you all for taking the time out of your busy days to join us today, and send those emails our way.